products. And this webinar is entitled Preserving the Human Right of Communication During Critical Illness. It will be presented by Callie Dayton and Joe Puntil. Both of these speakers have a long list of accomplishments, but I'll try to be brief because we want to get to the good stuff. So Callie is a critical care nurse practitioner and the host of the Walking Home from the ICU and Walking You Through the ICU podcasts, as well as a critical outcomes consultant. And Joe is a speech language pathologist and board certified swallowing specialist, specializing in communication and swallowing disorders in the ICU. She is also an internationally recognized speaker and an ASHA fellow. But what these two amazing women have in common is their passion for advocating for quality care and for early mobility in the ICU. Thank you so much to both of you for being here. We're looking forward to learning from you. With that, I will kindly ask everyone in the audience to hold your questions and for after the presentation, and I'll hand the floor over to you, Callie. Thank you.
Thank you so much. I'm thrilled to be with you all. Sounds like we have a very diverse international group with many different disciplines, which I'm thrilled to see because communication is the responsibility and the honor of all disciplines in critical care that care for any patients. It is a basic human right. The United Nations created a Universal Declaration of Human Rights back in 1948. This is Eleanor Roosevelt holding that declaration, and part of that was the specification that communication is a basic human right, meaning that every person has the right to express feelings, understand, be informed, to make decisions, to be given the tools to communicate, to be listened to. All of these things, it was declared as being part of our rights as humans. This is especially important in the ICU as communication can be life or death for some patients. The role of communication includes self-identifying. How often do we have patients coming in as Jane Does that are altered or intubated and now sedated, and they can't tell us their names? And that prevents us from knowing who they are, contacting their loved ones, providing optimal care. Communication is important for giving us a medical history, articulating allergies, describing their pain, sharing with us new symptoms, being informed, sharing their goals of care, being autonomous, helping make decisions for their own care and their own journey, be connected with their loved ones during some of the most vulnerable, pivotal, and even sometimes final moments of their lives, being able to share their preferences, their needs, and even their past traumas and triggers. Yet the communication in the ICU is not standard for most patients. There are many barriers, and I want you to ask yourself, what is the main barrier to communication in the ICU? What is the most common, the most obstructive to communication? If you answered sedation, you are correct. Look at this patient that's intubated. Can he communicate? Not really. And it's not because of the endotracheal tube, it's because of the sedation. Yet, a lot of times our mentality in the ICU is as soon as someone has a BiPAP or a tracheostomy or an endotracheal tube, they're not going to be able to communicate because they can't talk, because we can't hear them, because they don't have a voice. Yet this has become a very personal element of pain for me, as my family has been exploring nonverbal communication for a few years, and I want to share with you what that's been like. This is my daughter, Bea. She has mitochondrial disease, which affects the control of her muscles, leading. Can you guys hear it?
Yes, we hear you.
Okay. Kate, she just does it in different ways. In head nods,
Go. Again. More. Slide.
in physical gestures,
Raise your hand if you're excited to see the fire truck. Oh, everybody's excited to see the fire truck.
in sounds, and on her AAC device with her
Are they
eyes.
here? Are you sure? They're here? Hey, everybody, yes, they're here.
So, tell me, Bea.
Piggy tails.
Oh, you like piggy tails? How did you do like piggy tails? What's your other favorite hairstyle?
French braids.
And French braids. Yep, that's what you like, huh?
Tell Mimi.
I love you. I love you. I love you.
Oh, there you have it, Mimi. Bea loves you, huh, Bea? Yep.
Communication is not just talking. Communication is a basic human right that should be accessible to everyone, no matter the language, physical capacity, or modality, even and especially during critical illness.
Something that has to change in the ICU is the understanding that just because someone can't talk doesn't mean that they should not have the right to communication.
This is my
And yet,
daughter.
there are lots of complications in the ICU that can create barriers. Obviously, BiPAP, tracheostomy, endotracheal tube, but even neuromuscular disruptions such as stroke, Guillain-Barré, ICU-acquired weakness, and sedation, which we'll get into, cognitive disorders such as sedation, delirium, traumatic brain injuries, and language barriers. And yet, even while we're in the thick of all of those obstacles, we need to be zooming out and looking at how can we give our patients access to be able to fulfill all of these roles that communication can play for them in their care. But let's zone in to why so many times the access to these different roles of communication are immediately barred for patients. Usually it is because right after intubation, we shut the door and lock it, blocking us from communication when we start sedation. We know that sedation affects the central nervous system by binding to neurotransmitter receptors to reduce neuronal activity, which is a mouthful to simply say that when patients are sedated, they are chemically restrained. Their brain cannot tell their eyes to open if they are deeply sedated. Their brain can't tell their limbs to move. They can't grab a pen. They can't write on a paper. They can't text. They are chemically restrained. And when the patients cannot communicate, they are at 3 times greater risk of preventable adverse events. They are likely to develop frustration, anxiety, agitation, mistrust, trauma. And oftentimes people say, well, it is inhumane to have patients awake on an endotracheal tube and a ventilator. They need to sleep, not communicate. So then we need to ask, are patients sleeping while sedated? Is sedation sleep? Is it better to make them sleep or while they're sedated instead of being able to communicate their needs and what they're experiencing? We know that sedation disrupts the brain activity. Propofol, benzodiazepines, and opioids prevent REM cycle 3 and 4, ultimately leading to sleep deprivation. And when this goes on for days to weeks, patients are at high risk of developing delirium and having alternative, graphic, vivid, and traumatizing experiences that are far worse than anything they could actually experience in the reality of the ICU. Survivors have told me about experiencing kidnapping of themselves and or their children, being sexually assaulted, being cannibalized by their deceased father. On repeat, they could feel every single bite for days, being in the middle of war, being tortured, organ harvesting, experiencing severe isolation, abandonment, guilt, horror, pain that gets twisted into gruesome alternative scenarios that are more vivid than what you and I are experiencing right now. That is often what they are experiencing while laying there chemically strained with their eyes closed and being still and lifeless when it looks like they're sleeping. They're doing everything but sleeping. So when it comes to communication, when we sedate patients and immobilize them, they obviously cannot communicate, but even once sedation is off, we continue to have challenges in communication because of the delirium and ICU-acquired weakness that sedation has caused. Sedation, again, is our main modifiable barrier to communication. And let's focus in on how it causes delirium. We know that delirium is not just transient confusion, it is acute brain failure that doubles the risk of dying in the hospital. This is a life-threatening organ failure. It increases the length of stay in the ICU by 4.47 days. And patients that have delirium are at 120 times greater risk of having long-term cognitive impairments, similar to mild Alzheimer's and moderate traumatic brain injury. So we can think of this as a sedation-induced brain injury. And sedation or delirium is one of the main risk factors for post-ICU PTSD. There are different types of delirium, including hypoactive delirium, when patients are difficult to arouse, they seem sleepy, drowsy, lethargic, or hyperactive delirium where they're trying to climb out of bed, pull out lines and tubes, they're restless, they're fidgety, they're impulsive. And then there's mixed, where it's fluctuating between hypo and hyperactive delirium. And when patients have delirium, that alone creates a huge challenge to communicating, as they can have altered arousal. So they're difficult to even wake up, they can't communicate, or they're restless, they're fidgety, they're trying to climb out of bed, they're too distracted, they can't sit there and use a pen and paper to communicate. They've altered cognition. They can't put letters together to write words. They can't write out a sentence. They can't use a letter board because their cognition is altered. They have inattention, and they have poor motor planning that makes them lose their fine motor skills. This leads to the loss of the ability to write, text, use a letter board, even to answer yes or no questions appropriately. They therefore can't articulate pain. They can't share their experiences, their wants, or their needs. And that creates a huge challenge. And again, that can be life-threatening for our patients. For every 1 day of delirium, there's a 10% increased risk of death. So when we're having these symptoms of delirium, such as agitation, impulsiveness, if we resume sedation in response to that, that alone can kill patients. So when we're having delirium, we need to send in the SWAT team, the delirium experts that can get patients mobilized, give them access to communication, do cognitive therapy to bring them back to reality and start to treat that brain injury. When patients are sedated and immobilized, they're now going to develop or be at high risk of developing ICU acquired weakness, which is another barrier to communication. ICU acquired weakness is the symmetrical weakness of limbs and respiratory muscles. This is from atrophy and or dysfunction of the muscles and or nerves. Patients can lose up to 2% of their muscle mass loss per day in the ICU. Yet when they look at physical function, patients become more physically dysfunctional than their actual muscle loss. And we'll talk about why that is. But when this ICU acquired weakness happens, they're 30% more likely to die during that admission. They're 43% more likely to die 2 years after discharge. So this is a life-threatening hospital-acquired complication, oftentimes under our care and from our care. And when ICU acquired weakness happens, not only do they lose the ability to sit, stand, walk, independently breathe, swallow, but they also immediately lose the ability to text, write, type, point. This can make it very difficult to use these other modalities for nonverbal communication. A lot of this is because propofol, one of our favorite sedatives, impairs muscle function many different ways. As we talked about, it alters level of consciousness. They're chemically restrained while propofol is running, especially at higher rates. It deprives the brain of sleep. They develop delirium. Now they have cognitive dysfunction and can't use these other modalities for communication. It also causes absolute muscle disuse. They are immobilized. They cannot contract a muscle while sedated, and that leads to very rapid muscular atrophy. Then, lesser known is that propofol disrupts the sodium channel of the muscles. This decreases muscle excitability. So I want you to reflect on patients that you've cared for, and maybe they're young, healthy, strong people. They have a lot of muscle mass, and maybe they've only been sedated for 24, 48 hours. And you can see they still have muscle mass, but now they can barely hold a pen. They can't really hold the whiteboard or the clipboard. They can't really text on their phones. It's not because of weakness, it's because of decreased muscle excitability. They have lost that neuromuscular connection. So even once the propofol is off, maybe they're now waking up a few hours later, it could take hours to days to regain that neuromuscular connection and really have functional use of their extremities. We also know that propofol is a mitochondrial toxin, so it causes cellular dysfunction. So just because propofol is off, maybe it's metabolized out of the body, doesn't mean that they're just going to start lifting weights or mobilizing and regain their muscle function. They now have cellular dysfunction, a dysfunction at the cellular level, and that can create challenges to communication for far longer, even after the ICU. And I want to show you a video what this oftentimes looks like. This is a very healthy, robust 79-year-old that was living off the grid, chopping wood. When he had nausea, vomiting, his son took him to the ER. He was in the CT scanner when he vomited and aspirated, had an arrest. They resuscitated him for I think about 8 minutes immediately, intubated him, and then he was sent to the ICU for aspiration pneumonia. And without a clear indication for sedation, he was automatically put on that conveyor belt where he was sedated and immobilized. And about 8 days into it, he's now failing his breathing trials because he's delirious and he's weak, and his family's begging them to get him sitting at the side of the bed. And here's what it looks like once they finally do. Again, this is a man that was chopping wood 8 days before this. And I want you to watch if and how he communicates.
I want to see if you know where we are right now. Are we in the post office? Are we in the grocery store? Are we in the hospital? Okay. What state are we in? Are we in Nevada? Are we in Idaho? Are we in Utah? Okay, are we in Idaho? Yeah, we're actually in Idaho right now.
Now, can you see the delirium? Can you see the sluggish? Can you see the weakness, the decreased muscle excitability? Is this someone that can now tell his family what he wants in his goals of care? Can he now articulate whether or not he wants a tracheostomy, whether he wants to go to LTAC, what he wants to do that day, what his preferences are? He can't articulate any of that. So yes, he's answering yes or no questions, and not always appropriately because he's confused. We don't really know what he wants. We've taken away his ability to communicate, not because of the endotracheal tube, but because of the sedation that was given. Sorry, trying to get to the next slide. So then we get locked into the cycle of we automatically start sedation, which alters cognition, decreases muscle excitability, causes weakness, leading to the inability to communicate, which can then lead to lots of panic and frustration. Patients have said that I was trying to say, don't kill me. Where are my children? How's my dog? And yet they have this anxiety and agitation. What is the auto set reflexive response to that in the ICU? It's to give more sedation. So we give sedation, we cause delirium, which causes agitation, and we respond to it with sedation. This is a very lethal process of care and cycle that we get locked into. And if we were to provide communication up front, maybe we wouldn't have to get sedation. Maybe we could understand what they needed, treat their symptoms instead of causing more anxiety and angst. Let's put yourselves in the shoes or the bed or the gown of a patient. This is Susan. Imagine you are Susan. She has ARDS, and you can hear and feel everything and everyone around you, but you're unable to move because you are chemically restrained. You're unable to communicate. You have zero control, and now you're lost in delirium. And here's what Susan said that she experienced.
They were terrible. The delirium, and I'm sure that was from those strong drugs. I was laying there and I couldn't move, and I felt like I was pinned down, but I knew I was in the hospital bed, and I could see babies floating all around me, and there was a fire around me, and I couldn't help these babies, and it was the most terrifying feeling in the world to be laying there. There's a fire, and I'm worried about these babies. I can't get to them, and they're going to die. And it was horrible. I mean, it was traumatic.
So you experienced that for days.
They were terrible.
And during an awakening trial, once you're finally looking towards extubation, now the team's finally going to be looking at liberating you from sedation, and you're able to kind of start moving, but you are scared, confused, and you have serious questions. How are the babies? Are they okay? Where's my husband? Where's my daughter? But you can't talk. You're given a pen and clipboard, but you can't get your hand to hold the pen. You can't really hold the clipboard. It just flops into your lap. And the nurse can't figure out what you're trying to say, and you get frustrated. And you start getting grumpy and agitated. Maybe you're pulling up their restraints more to get more room to be able to write better or whatnot, and you're acting frustrated. Now, what's the nurse going to do? You get worked up, panicked, impulsive. You show signs of discomfort or distress, and you seem agitated, which can mean anything in the ICU. It can mean blinking your eyes to trying to karate chop a nurse. But if we say agitated, how's the team going to respond? They're going to slap a Band-Aid on it and resume the sedation, which that will not treat any of the causes of your distress, your pain, your questions, your needs, your delirium. We're just going to slap a Band-Aid on it and perpetuate one of the very causes of your distress. And this puts patients off into a very different pathway than we intend to. When we intubate patients, and if we sedate them, we immobilize them, we cause delirium, isochord weakness. This leads to prolonged time on the ventilator, hospital-acquired infections, and ultimately death. That man on the video that I showed you, the 79-year-old that was chopping wood and got nauseous, he died in an LTAC a few weeks after that. Not because of aspiration pneumonia, but because of delirium and ICU-acquired weakness. These are lethal repercussions. And yet, if they had woken him up right after intubation and let him communicate, would things have been different? We need to understand that These complications are not just in the moment. When we sedate and immobilize patients, cause delirium and acquired weakness, we set them up for long-term cognitive, psychological, and physical impairments or disabilities that are called post-ICU syndrome. We are changing their lives forever if they do even survive our care. So when patients are agitated, instead of setting off this whole pathway, we need to be looking at what's causing that. That distress is a symptom of something. Is it delirium, pain, need to have a bowel movement, concerned about their dog in their apartment not getting fed? Are they withdrawing from medications or substances? Do they have questions about their care, etc.? Sedation will not treat any of that. Communication will allow us to know what they need and to be able to treat it instead of blocking access to all of these roles for communication. And that's in the form of the ABCDEF bundle. That is how we give patients the access to communication. This bundle provides, each letter represents a different aspect of care. A is for ask if they're in pain. CPOT, which is assessing for symptoms of pain, physical manifestations of pain, should only be used during sleep or during exceptions like status epilepticus or the inability to oxygenate with movement, times where sedation is unavoidable. Then we can use CPOT. Otherwise, we need to be asking the patient directly, communicating with them and from them if they're in pain, and treat that pain. B is for both awakening and breathing trials, which should be turning sedation off as soon as there's no longer an indication for sedation, which for most patients is right after intubation. And then we turn the ventilator off as soon as parameters are met. C is choice of sedation and analgesia, meaning we ask after every intubation, is there an indication for sedation? Is it worth depriving them of communication, their basic human right? Or can we see what they need? Can we let them wake up after intubation? And if there is an indication for sedation, like intracranial hypertension, then we choose the safest sedative at the lowest dose for the shortest duration possible. We're going to circle back every shift, every day, and say, is it time to take sedation off? D is for prevent, treat, and assess for delirium, which means that we avidly avoid medications that cause delirium. We engage family, we allow patients to get real sleep, and we mobilize them. Now, when we automatically sedate them upon admission or after intubation, we're giving deliriogenic medications. We're depriving them of family engagement. We're depriving them of real sleep. We're depriving them of mobility. We cannot practice the D of the bundle if we're automatically starting sedation. And E is for early mobility, meaning preserving their baseline function, getting them up and mobile. I worked in an awake and walking ICU where we allowed patients to wake up right after intubation, and we had them doing their highest level of mobility within 12 hours after admission, even and especially after intubation. That was early. We preserved their baseline. F is for family engagement, letting them be awake and communicating to and from, having communication to and from their patients to the families. This is what the ABCDEF bundle should look like for most patients. Now we can see there's a spectrum of compliance. Some teams may only be doing awakening breathing trials towards extubation. They may chart light sedation, but patients really do not open their eyes and make eye contact to voice, let alone communicate. But the full compliance with the bundle means that they are awake right away and strong, and that have their strength, their muscle function, and their cognition intact enough to use a pen and paper, to text, to use those low-tech instruments for mobility. When we fully comply with the bundle, we can have access to communication promptly, and that is what helps us keep sedation off. The goal of the bundle is to have patients as awake, communicative, autonomous, and mobile as possible. It's not just about an on and off switch for awakening trials. It's about right away looking at how do we give them access to communication, which will make everything easier. Though the bundle has been around for a long time, it's been very misinterpreted and poorly implemented. So culturally, the bundle has been interpreted as A, being start fentanyl upon every intubation, increase sedation if they seem uncomfortable. B becomes start sedation on everybody, but once ventilator settings are low, once vasopressors are off, now turn sedation down enough to see if they've had a stroke, and then turn it back on if they're not ready to be extubated. C becomes start sedation opioids on everybody, but try to avoid benzodiazepines since they're the worst. D becomes make sure you chart CAM and RAS, which we'll talk about. Early mobility becomes order PT and OT after extubation. And F becomes allow family to visit during the day. Now let's talk about that RAS, how sedated someone is. Most sedation orders, at least here in the USA, are for 0 to -2. This is a Richmond agitation sedation scale that is used to titrate sedation. So the order should be to have patients awake and completely calm oriented, or calm and paying attention to the caregiver. You walk in and their eyes are open. -1 is when you walk in and their eyes are closed, but you talk to them and they open their eyes and make eye contact for more than 10 seconds. -2 is when their eyes are closed when you walk in, you talk to them, and they make eye contact for less than 10 seconds and then drift back off. Most sedation orders for most patients are from a 0 to -2. Now, when you go out to your units, I want you to talk to patients. Don't touch them. Just talk to them. See, do they respond to touch or to voice? Or do you have to touch them to have a response? And if you do, that's closer to a -4. If they do not respond to touch, then they are -5, which is deep sedation. And that's an independent predictor of mortality. And then CAM is the assessment tool. We won't get too deep into it, but it's looking at the 4 features of delirium, which is acute change in mental status, inattention, altered level of consciousness, and disorganized thinking. Right now, in a lot of our ICUs, people may assume that just because a patient follows commands, that they're not delirious. We need to be doing a full CAM assessment to looking at all of these features of delirium to make sure that we're truly screening for delirium. But I want to talk about this light sedation. People say, yeah, we practice the bundle because our patients are lightly sedated. When oftentimes I see in manual audits that 60 to 80% of those RASS scores are inaccurate. So patients are oftentimes more deeply sedated, but let's say that they are lightly sedated, meaning you go and you talk to them and then they open their eyes and they look at you. Is that really communicative? You can say, are you in pain? They answer yes or no. That's good. That's a certain level of communication. But is that someone that can hold a clipboard, write out exactly what they want and need? Is that someone you can talk about goals of care with, end of life discussions? Can you really have high level, true communication with someone when they're lightly sedated? Even light sedation is a barrier. But the only way we can really have patients truly off of sedation is through communication. We have to know what they need and treat their needs in order to help them be awake and mobile on the ventilator. And this is just as important as anything else we do in the ICU. It truly is. We need to treat it like any kind of lines, drains, mobility screening tool in terms of communicating it in handoff. So for RN to RN, RT to RT, every time we hand off our patients, we need to say, here's what they're here for, they're intubated, here are their ventilator settings, and they communicate with a whiteboard. And they communicate with a cell phone, or they use an app. We need to articulate how they communicate because that tells us so much about their cognition, their muscle memory, their muscle function, but also it prepares the entire team to go in and communicate with that patient. That's exhausting to have to say, hi, I like to use my cell phone. Can you grab it off of the charger across the room? They go in prepared, and it keeps the entire team focused on communication. If they can't communicate, that should be the exception. That should be a red flag. Why can't they communicate? What's wrong with them? Do they have delirium? Why are they sedated? Those are the things that we should be asking instead of just assuming, okay, they're intubated. Of course, they can't communicate. This means that in rounds, we bring it up. The RASS score, CAM score, how they communicate, and write that on the whiteboard. Someone can walk in, the CNA can walk in to answer a call light because they should be waking up to use the call light and look at the board and be like, oh, you'd like to use the clipboard. I'll make sure you have that. We need to prioritize communication and standardize it in our ICU because it is a life-saving intervention. And here are I'm going to pick a few stories because I have so many to share, but I was visiting a team and they had an ARDS patient that was intubated for aspiration pneumonia, newly intubated. And so we went in to mobilize him. It was just hours after intubation and he was hard of hearing. So they had to use hearing amplifiers, which was great. He had a little bit of a hard time writing because he had just some learning disabilities at baseline. And they were really nervous about mobilizing him because it was the first intubated patient they'd ever mobilized. And the physical therapist was a little bit rough, kind of like, I think expected him to be very weak and a little bit manhandled him, meaning got on the side of the bed and basically picked him up and put him in the chair. Even though it had just been hours after intubation, he was walking. He was ready to walk. So there was a little bit of a gap in assessment, communicating with him. What can you do? Having him do things beforehand. But bottom line is, after everyone left, and there had been a few of us in there to help watch the scenario, there were more people than were needed because it was a new and exciting thing. After he left, he wrote on the clipboard that he had a lot of PTSD and it had to do with people touching him and a group of people being around him, and that was very triggering. Being able to know that right away in that first day, we should have known that before we ever touched him, but being able to know that from then on out, they were very careful about how they talked to him, how they treated him, how they touched him. Instead of him being triggered and going into a panic attack from his PTSD and then being sedated, him being able to communicate that trauma changed the entire course. He remained awake and walking on the ventilator, was extubated and walked out of there. where he could have had completely different outcomes. A podcast listener told me that they had a patient completely off sedation, used the call light while intubated. He went in, they had already written on the clipboard, chest pain. They did a chest x-ray, and as they were looking at the machine, they saw a large pneumothorax, and in that moment, he arrested, and they knew exactly what caused it. They were able to intervene and get him back. A pneumothorax would have been very low on the differential list during a code, and they could have lost him. But communication, being fully awake and able to use a clipboard with no one else in the room, use a call light because he was completely off sedation, saved his life. I had a patient that had muscular dystrophy, and it was progressing and probably led her to have aspiration pneumonia. She was flown to us from an outside hospital, a community hospital. She's from a reservation. She was a Native American. And she was sedated for transport. We woke her up right away, and she really only had use of her finger and her thumb. She could just barely write. And she immediately had us calling her sister. And she was asking her sister where her daughter was, because her biological dad was not a safe person. And if she was not there, she found her under the custody of the reservation and would then be under the care of her biological father. And she was very concerned. So here we were, she was intubated, able to write a little bit and articulate those specific needs. They brought chiefs from the reservation so that she could sign legal documents protecting her daughter and making sure that she was safe. She was able to make the decision to have a tracheostomy and to go to LTAC, deciding that she actually wanted to do that. She made all those decisions while intubated, even though she only had her finger and her thumb. That changed her entire trajectory, and as well as protected the life of her daughter. That I could not have guessed any of that with a yes or no question. At a RAS negative tube, I'd shaken her and said, "Are you okay?" And she just would have been like, "Yeah." That's completely different. That's not full communication. Another podcast listener said that she had a patient that she got a report was agitated, kept failing his awakening trials because of agitation. And so she went in and she took sedation off and said, "What do you need?" Gave him a clipboard and he wrote Wellbutrin. He was withdrawing from Wellbutrin. They got that for him. He calmed down, stopped withdrawing, and they got him extubated like an hour or two later. That changed everything. Sometimes patients just want to scratch their nose. They just want to scratch their back. They want so many things that are just so little. And we threaten their lives by choosing sedation instead of communication. And so these are some of the pictures and examples of patients and what they've communicated. Sometimes they just want booze. Sometimes they want to express love and appreciation. It changes the entire atmosphere and the fulfillment of clinicians' experiences in the ICU. When they're able to tell them what they want, what they need, they know that they're treating them according to their wishes. It decreases the moral injury that happens. And this should be a key and fundamental basic of care in the ICU. And I'm going to punt it off to Joe.
Well, thanks, Callie. Everyone's going to want you to be an honorary speech therapist. I'm going to share my screen. I'm hoping that I can get this going because we have, I assume, a lot of questions. Let's see, slideshow, start from current slide. Yes, I did it. Not the best at IT. So thank you, Callie and Jenny, for putting us all together. I'm going to be a little bit more broad. I'm definitely going to talk about what we do in the ICU, of course, but more broadly. So I think my role as a speech pathologist is my home away from home. I work in a level 2 trauma center. I've always worked in either a level 1 or level 2, but I believe that speech pathologists should be involved on any low or high velocity trauma, intubated or not. We should do every single concussion eval. And we're primarily not just working with patients' ability to think and all that, but also the education to the family, which you're going to hear me talk about a lot. Any head bleeds, all neuro patients, respiratory failure, medical fragility, viral issues. We have the nurses in our facility do swallow screens. I'm not going to talk about swallowing now, but we are on all vent and trach patients. Let me see if I can. Okay, I'll do it here. So when do we get involved in our institution? Whenever I've developed a program, we get involved with people who are intubated right away. And I have the honor to work with these fantastic PTs and OTs that we are a lot of walking and mobility ICU, and our ICU nurses are into getting people up and moving. So PT and OT get in there with respiratory when people are intubated. And our job as a speech pathologist are to go in and figure out what's the best means of communication for them. And the one thing, and I'll talk a little bit about it when I get to our communication boards, but what I keep getting pinged about from people is, I don't know about you, but if I woke up in an ICU, I'd extubate myself and say, get this thing out of my throat. But speech pathologists are kind of cornered into that laryngeal market. So what happens when people are intubated, and Callie can probably talk about it a little bit more, is the gag reflex is dishabituated a lot for a lot of reasons because you've got something down there. So it's disconcerting, but they can handle it when they're alert and they're communicating, as long as they can communicate. So in our institution, we get people up and we move them, and then we figure out what's the best communication board. How difficult of a communication board should we do? How easy of a communication board? And I think that's the role of the speech pathologist. We have, and the PTs and OTs really, really use those a lot with them. Just very quickly, over 5 million patients are admitted annually. At least 20 to 40% of these are intubated. And like Callie said, the overall mortality rate can be high. What bothers me as a speech pathologist is with these people that survive ICUs, at least greater than 50% have some type of cognitive impairment that we call PICs afterwards. And then at least over 60% can be a functional impairment. And Callie so eloquently said, the brain is just always on. And our brain is always on. It's always thinking. It's always listening. It's tactile. It's always on. And if it isn't, you're not alive. So any kind of life-threatening disease will affect the brain. And that's what happens with this. Even though like she said, you're sedated, your brain is still thinking. And so what we try and do is wake them up and get them communicating and get them engaged so that they don't lose those cognitive functions. And she said this very well about the critical illness. It talks about worse outcomes, consequences beyond their hospital stay, and definitely PICs. I love this slide. I will definitely give this to Jenny. There's a lot of people are asking for these. The deleterious effects of what we do in ICU is what actually is the outcome of those, the weakness in their legs and arms, their cognitive impairment, all of the things that happen in critical illness, we can actually prevent. And it reminds me of when I used to I've worked in the NICU for many, many years. We do bundled care in the NICU. Why don't we do that in an ICU, in an adult ICU? Why are we waking these people up all day long with labs and with CTs and with MRIs? And why don't we do cluster care for these? So these people can get sleep, hours of sleep, 3 or 4 hours of sleep at a time, awake during the day and asleep at night. So she went over ABCDEF. She went over those very well. This is someone in our institution during COVID who's awake, he's alert. We were communicating with him. The nurse was communicating with him. But I want to show you this picture that my colleague Belinda gave me when I was lecturing one time. I said, hey, can you go into there and look at it? Take a picture of the ceiling, because this is what your patient gets to see. And that can be disconcerting to patients too, is because they're laying in a bed, they're intubated, and every time we wake them up, they're seeing this ceiling. And so we're trying to do things as speech pathologists to decrease the delirium. What can we do? The PTs and OTs can get them mobilized, but speech pathologists can do a lot about delirium. Our activity is early mobility, but also communication and cognition tasks, sunshine therapy, get them out in the room. I did that right before we came on. I had a patient who was intubated and in the ICU, and a colleague of OT and I were going to go in and see him, and the nurse is like, nope, he wakes up, he's thrashing about, so he's totally sedated. And I went back and politely said, turn him off. I want to see why when he wakes up and he's all agitated. I want to know what's going on. And I gave him a communication board, and he was concerned about where his wife was. And he's got 15 dogs and a ranch. And that's what he was concerned about. That's all he wanted to know was, where is everybody? Why am I here? And where is everybody? So I'm going to show you some communication boards that we use, and I'll share those as well. Sleep is huge, medication review, but our role, because we are so good about communicating. I mean, speech pathologists, nurses will say, well, even if someone comes in with a stroke or is altered mental status because they're septic or whatever, they'll say, well, you're not going to get much out of them because they really can't follow commands. They're not doing well. They're not really communicating. Well, that's just like right up a speech pathologist alley, because we can read people's minds if we've never even met them. We're really good at figuring out by interviewing that patient's family member in there. So it's open communication as a speech pathologist in delirium management. I always like to tell people when I mentor them or I do any kind of lecturing that you're talking to that patient and you're evaluating that patient's ability to follow simple commands, complex commands, level of attention, all that. But you've always got to keep an eye on that person in that room that's staring at their loved one and thinking, Is my husband going to be in diapers the rest of my life? Is he going to be able to communicate with me? I don't even know. Like, I don't know how to handle the ranch. I don't know. I know this part of the house. I don't know that part of the ranch. And so the consistent education of the family members is what's, so I just go to a store and I buy like 20, 30 notebooks and I hand it to the family member and I say, you need to journal, and I'll talk a little bit about that. Glasses, hearing aids, sleep-wake cycles, continual orientation throughout your whole session. Hey, you're in the hospital, you're going to do really well, you're doing much better, you're going to be coming off this ventilator soon or BiPAP soon. And that's what our role is. She had some great pictures about early mobility, as do I. Here's a woman who's clearly up in a chair and moving. This is during COVID. This person had a GI bleed and she had a trach, and this is the whole team. So it's a PTOT speech. I'm taking the picture, and respiratory therapy. And during COVID, I follow rules and I don't follow rules. But as far as I was concerned, during COVID, it was really the delirium went out the window with delirium because we all look like bandits. And so she didn't have COVID. So I always took my mask off when I got in a room, got in trouble for it. But that patient really, they'd light up and say, there's a human, and they're even able to talk to me. So we're doing speech with this lady. We're doing leak speech and valve speech, but I treat the family members as much as I probably treat the patient. This is what you're going to expect, especially a brain injury with Rancho levels. This is what you expect. This is what I want you to do. This is what's going to help his brain. And so that's why we like to get involved as soon as possible. This gentleman clearly is intubated. He's alert. He's got an NG to suction to decompress his belly. He's probably got some ileus. Then he's got a post-pyloric feeding tube in. But he loved to read, and his son would come in every day and read books. I don't know if I would pick a book about war, but he said his dad really liked that. And so I get family members engaged in what's happening at home and the things that they're important to them and is concerned to them. So here's family engagement, of course. We start early. Callie went over this. I'm going to have some time for questions. So these are the basic communication boards that we use. I like bigger letters, and we tailor it. We have four. I work with 3 other speech pathologists that are fantastic, and we all work in the ICU. So every one of us will be in an ICU. You know, we all have our ICU patients, and so every one of us is in there. All the nurses and doctors are used to it. But we put on the top of it, like, what happened to me? Like, head the bed up, head the bed down. Oftentimes they just want to have their nose scratched, or I'm nauseated, I'm throwing up. You know what I mean? Like, do something. I'm sick. Leave me alone. Read me a story. Don't leave me alone. Things like that are what patients need in order to communicate. These are some other ones if they can point. I've had quads be able to, when they're trached and stuff, be able to point with, do leak speech, or to be able to point with something in their mouth. We have eye gaze boards. These are other ones that we've used for patients. But we cater the communication board to the patient. And so oftentimes what I'll do is I'll ask the family members, do you have any kids, grandkids? Tell me a little bit about it. And I'll type those up. We laminate them, and then they can point to the animals or the grandkids, and they'll be able to point to those and say, what's Jared doing? What's Christy doing? This is the journaling. And so this is, I think it's huge. When you ask a patient, go to the store, get a journal, write things down, they're like, yeah, but they won't do it. So these are 97 cents at Walmart, and I just buy 20, 30 at a time, and I bring them into the hospital, like 10 at a time, and I hand them to the person, and I say, I want you to write down when you heard the motorcycle accident, when you got that phone call, when you came to the hospital, what was that like? And I want you to write down your fears, your frustrations, the scary parts, the things that got better, and date them and time them, the smells and everything. Because when your loved one does get better, they need to see this. And you need to see it. You think you're going to be able to remember it, and you're not going to be able to remember it. So there is communication for non-invasive ventilation. There are companies that provide amplification for people with NIV, which is like BiPAP and CPAP. I want you to watch this really quickly.
Let's try this again. Clear communication is a vital part of healthcare. If you don't understand what I'm saying, you might miss something important.
What's wrong, Mr. Fields?
Were you guys able to hear that? I hope. Okay, I'm just gonna assume you can.
We
But
heard it, thank you.
okay, good. So there's communication when you're intubated, and then there's communication. So our respiratory therapy, this device, if you can get this device, it would be fantastic because you take it off and you're like, what? You got to go to the bathroom, and then they decompensate, and you put them back on there. You know what I mean? And it's just hard for people, and they feel like they're smothered. But if they can communicate their fear, really de-escalates, and their ability to tell end of life or what they want. Do you want to be intubated or not intubated? And a physician or a mid-level can come in and have a palliative care, whatever, have a frank conversation with patients. What's nice is that you can plug something in to the loudness of ICU, put it in your ears, and you can hear that patient much better. So it's a nice device for people to be able to communicate. One of the things I've been working on with patients in ventilators from the time that I actually started being a speech pathologist way ago. And long time ago, we can either do leak speech, where you can just deflate the cuff and communicate with a ventilator, or you can do valve speech, where you deflate the cuff, suction them, put a speaking valve on, and then be able to communicate with a speaking valve. And there's a lot of benefits to that as well. A lot of benefits to that. So there's a company that's called Atos. I have my good friend Carmen's email out there if you need to email her. But Atos has a trach tube that you can inflate with and keep on the ventilator, have it inflated. They also have a port that you can suction above the cuff and your pilot to inflate the trach tube for the cuff. And then what you can do is you can suction above the cuff, and you can also allow air to go above the cuff and communicate. So if you've got a patient, like say on a PEEP of 10 or a PEEP of 12, and they're like, nope, if we do that, he won't be able to recruit, he won't be able to come, and you want them to communicate, that person will be able to communicate trached with a cuff inflated with above the cuff. They also have a speaking valve that has a variable resistance so that they can communicate with a speaking valve when they're trached. Of course, there's also the passing mirror valve, which has a ventilator valve and a speaking valve for people that are on a ventilator and off a ventilator. And there's a lot of positive things about this. Absolutely, for speech pathologists, is like a no-brainer. But this allows people to be able to communicate and swallow while being tracheostomized. Also, just hearing devices. I mean, how many of our patients are older and then you can't hear? And so we have things, I used to be able to buy this at Radio Shack. That was a long time ago. That went out of business, but you just put them on their ears and you talk in it, and it's really loud. And then guess what? This person that they say is confused and not following commands is just hard of hearing, and then so he can't hear what you're saying. They're panicking. And so our palliative care team has a pocket talker, and then all of our floors have it so that we can use them with each of our patients in each of the floors. I really like this. This was a nurse's project probably 15, 18 years ago. And we put this in everybody's room in the ICU that's intubated, that's going to survive. We kind of did a hiatus about it when COVID hit, because we got to know people and then they died, and it was harder and harder on nursing staff. But I really like this because you can put everything on here that is important to that patient in that room. And it's an amazing amount of information, and it really like humanizes that person, because what we see is this person that's got lines and things all over them. And as speech pathologists, we use this for anybody that's apraxic, aphasic in the ICU, maybe not, intubated, but we get to know them that way. I had a patient one time who was aphasic and apraxic. I'm pretty more apraxic than aphasic, and his favorite movie was Young Frankenstein, which happens to be one of my favorite movies. And so I know pretty much all the crazy lines about it. And I started singing, roll, roll, roll. And he just got up and he started singing the song with me. And I'd throw a line out and he'd imitate it. And I would never have known that if I didn't have this Get to Know Me poster. People travel through Utah. I work at St. George Regional in Southern Utah, and people travel through here a lot. We had someone from California, and she was intubated. And what she did for a living, if you can believe this, is she was a belly dancer, and she taught belly dancing. We had a physical therapist that worked here that used to belly dance. And so when we turned sedation off and we kept her awake, guess who walked in? The PT, and started belly dancing with her. And she did so much better because we connected with something that meant something to her, instead of us playing the guessing games. So our RNs really like these. This is what it looks like. We throw them on a big door, and then there's pictures of everything, so we know like all the grandchildren or the nieces or the nephews or whatever's going on with the patient, we know what that looks like. And we have these hopefully they get transferred when they go to a different floor. Sometimes it gets thrown away, and my colleagues laugh at me, but I do have a come apart because I'm really personally involved in all of this. But it helps us understand what they like and don't like. I've had patients who they don't like their feet tucked in, and so there they are thrashing about the bed. They're throwing their legs around. Everyone's going to try and tie this guy down when guess what? Just let him let his feet out. He doesn't like his feet tucked under the bed. So that's just a really easy thing to do. Kelly went over this. It's clearly should be patient-centered care. I'm in rounds. My colleagues are all in rounds. I try and get to rounds a couple times a week. So do my colleagues, so that when they talk about their mobility scores, we'll say, how are they communicating? So that we remind nurses that it's appropriate for someone to be able to basically tell them what their needs are. So I wanted to kind of scroll through this very quickly because I know there's going to be questions. We get involved really early. And someone's going to say, well, how do you bill for that? Well, I don't bill for putting up a poster and educating a family member and finding that out. And I know that's going to take time, and we all have productivity measures, but that connection to the family means so much to them, so that when you go in and do your evaluation, you know what that patient was like when you were in there giving everybody education, their levels because you were watching it. So you're kind of doing an evaluation. And then once that person is extubated and you can really do some excellent cognitive and communication stuff, you already know what they're doing. I help organize cluster care. We do communication boards, and like I said, education. My final comment is communication is the key part of humanizing the ICU. I don't understand how anybody can't think that's important. And I know that's why those of us that are speech pathologists on here, we feel that we're championing that, but we don't want to be the stepchild. We want to be part of the team. Communication is a right, and family members need to be involved as much as that patient. So I always tell people when I'm training them, read the room. If you can do anything, learn how to read a room. You walk in and you can always tell when something's tense. You can always tell when there's conflicting family members, all that kind of stuff. And we're really good as speech pathologists. PTs and OTs are good at this too, but we're really good as a rehab team to read the room and figure out who's gonna need the most support, who's the one to do this, and give them things to do so that patient get better. Sometimes family members want to help shave, want to help them do that, and work on their cognition the whole time. So I'm gonna stop sharing. I think that's my last one. I do have our emails here. Again, Kelly put that in the beginning. I think we have time for questions, right?
Thank you, Kelly, and thank you, Joe.
Sure, let me stop sharing. You don't want mine. Okay.
Thank you so much for being here. We do have a few minutes for questions, so we can take a couple if everybody would kindly either put them in the chat or the Q&A. We have one person asking, do you get a speech order on all ICU patients?
I'm assuming that's for me. So in our institution, so remember, I don't get them on all because we don't need to be on all patients. We really don't. But we do get orders for, like I said, low and high velocity traumas, all neuro patients, we get them. Anybody that fails a nursing screen post-extubation, but we're usually on them when they're intubated. We're usually on patients on high flow when they have high flow, so we can do swallowing of vowels and communication, but we're on patients that are appropriate. So that's why in rounds, oftentimes PT and OT and speech get ordered together, because we tried to change my goal was to change the semantics as much as possible. Instead of saying, well, PT and OT are doing this, they try and say, well, PT, OT and speech. So sometimes they think it's funny when I say and speech, and they go, yes, and speech. So they write it on the whiteboard, but we're on a lot. I mean, we always have patients in the ICU. I mean, I've worked like that my whole career. So I think it's a home that we need to be in, because we're so good at being the center of that wheel to kind of help everybody get together for that patient's goals of care. Did that answer the question? Okay. Not on everybody. We're not appropriate on everybody.
And can I say, might depend on the context or the environment of the ICU. Working in an awake and walking ICU where they've done this for almost 30 years, where patients are awake right after intubation, they are able usually to access lower level tools. So as a nurse, I didn't need a speech therapist to tell me to grab a pen and paper. That was just as auto as, grabbing my antibiotic. Like it was just pre-programmed. So in that kind of environment, it was easier. Now speech did cognitive therapy with patients that were still intubated when we needed them. So that role was different in that kind of environment. I trained another ICU where one of the speech therapists said, for the first phase after rollout, as everyone's getting used to having patients awake on the ventilator, please consult me and I will come in after every intubation and help everyone identify which tool is the most appropriate. So I thought that was a great use of bridging and bringing in that education and developing that skill set throughout the rest of the team as the expert. Now, 4 or 6 months later, she doesn't need to do that anymore. Now she can kind of redefine where am I best used, but initially they needed her. And she came in as that extra reminder saying, hey, remember about communication? Why can't they communicate? And so she was able to insert herself to achieve that goal.
Yeah, I think it's a lot about advocacy too, right? I always see the orders for PT and OT, and it's like you, Joe, it's like, don't forget about speech, because I think at the end, when you're treating the whole human, it's everybody's job. And when we all work together, and the more interdisciplinary it is, the better for the patient outcomes. And somebody asked, let's see, how did you begin to change the old way? Kelly, I know you do consulting in a lot of different ICUs all over the world. Like, and Joe, in your experience, like, how do you take those steps? How, because a lot of people like to say, well, this is how it's always been.
I started in that ICU in 2012. And at that point, they'd already practiced that way for about 15 years. So it was already very established in the culture and the practices. No one made a big deal out of it. So I didn't think it was a big deal until I became a travel nurse and got to experience the old ways. And I just didn't understand a lot of why we did that in my first ICU, why they were sedating patients in the next ICUs. So I did that for a few years. I just went with what was normal. And I went back to my first ICU and I had a lot of questions. And that's what spurred me on to create the podcast, Walking Home from the ICU, because there were so many things that I didn't know. And I knew that if the things that I was learning were unknown to my previous colleagues in these 11 other ICUs, and if they knew that, they would change. And so as I do consulting now, I carry that with me to say, what things did I not know that would have impacted how I cared, how I would have critically thought through each patient. I would have made sure every patient had access to communication instead of allowing this malignant normality to take over. So I've trained 13 teams now, and I've learned that you have to start with a why. You can't change practices unless you change beliefs, perceptions, and knowledge. And it's not just about not giving sedation, it's what you do instead. So for example, communication, I thought it was so instinctive. But then now I'm on site with these teams and I say, okay, we're gonna get sedation off. Where's your clipboard? And they have to hunt throughout the entire unit to find the most basic tool. And I realize, oh, I have to teach them that. So making sure that we're understanding why we need to get sedation off, what's at risk, but also what are we going to do instead of sedation? So the why and then the how needs to be kind of our primary building blocks.
And as a speech pathologist, if you want to get involved in the ICU, the best thing to do is to go to rounds. I mean, you just go to rounds and be present. And then they'll say, oh, you probably need a consult. When I first moved here 21 years ago, I was told speech therapists don't work in an ICU. We see them when they're out of the ICU, which just like blew me away because I've worked in an ICU since I got out of grad school. And I went, oh, okay. And I just started working on the weekends when nobody wanted to work and walked into the ICU and said, well, this is what we're going to start doing. And you just go slowly by educating. And it's a constant education, but it's worth it. It's totally worth it for patients.
Yeah. People that are bringing these changes that are revolutionizing the old ways, I call them revolutionists. And I think it's important that no matter what discipline you're from, that you be asking certain questions like, what is the indication for sedation? And mechanical ventilation alone is not an indication for sedation. And then why can't they communicate? No matter what discipline you're from. And if you're an SLP and you're in an environment where they're like, you don't need to be here, be bold, find a way to tactfully navigate that, but don't back down. You might find nurses will slash your tires if you ask about sedation, but keep persevering and then offer help. Say, how can I help you? Can I go in with you when you do the awakening trial? And that might be really jarring for nurses initially, but that's okay. Just embrace it, prepare for the hesitation, but just be bold. Can I go in with you and help them navigate those communication barriers, the agitation, bring in your other rehab colleagues, set them up at the side of the bed, give the nurses the support instead of saying, yeah, the nurses don't want to take off sedation, so they get to determine everything. Instead, say, we're going to help you because they are scared, but you guys have these skill sets that they need. So be bold and inserting yourself and providing that help.
Yeah, I think it takes a lot of initiative from our end too. And I do want to commend everybody who's here in the audience today, on your own time, learning more about this for your patients. And we have had a turnout that was incredible from every corner of the world and every discipline. We'll do one more question and we'll wrap up. I did put the email contacts for Callie and for Joe in the chat. So if you have questions, I know they're both happy to work with you and help. But the last question we'll take is from a PT student, and he's asking if we have difficulties when communicating with patients in the ICU, should I get SLP to work with the patients first, or should we work together at the same time?
Together. You know, if you can, together, because a speech therapist can sit or a speech pathologist can be in a room with an OT and a PT and just watch what they're doing, and we can do a cognitive eval with them just by not even asking a question. We can just watch the interaction, and we're really good at knowing where people's levels are. So we like to go in there with PT and OT when getting them up and moving them, because once you get them up and move them, then they're moving and then they're doing things. And so we can jump in and say, this is the best way for them to communicate with that. We're really good about being able just to observe and visualize and then decide what's best for that patient. We don't need to see them separately. They do better when they're moving anyway. They're up and more alert. So there's a question in there, if it's okay if I go a little bit over. Someone's asking about evidence-based medicine in the ICU, and Callie has a lot of those, right? Callie, you have a lot of those statistics about movement and communication and evidence-based medicine to take to your physicians about why is this, what does this do? Is this really that important? And so we'll try and get that to you. Someone's asking that question. That's a really good question. Like,
yeah.
One person in the chat was saying, you know, how do you get your trauma people on? I go to trauma meetings. They're at 6:30 in the morning. I'm not a morning person. I hate being in a meeting in the hospital at 6:30 in the morning, but I'm in a meeting with the trauma people because once they see you there, they start recognizing your role. And you're just really quiet and listen things. And then all of a sudden you'll start getting more and more consults. And so that's how we got on every low and high velocity trauma, all that kind of stuff. And then there's turnover. You have all these mid-levels that are turned over, and then they need to realize, oh, that's right, we need to get speech on the case. And sometimes they forget about it. And then, so we have the privilege of being able to write orders. You know, our docs are like standing orders. We don't write an order for you if there's a trauma, just write an order. Whenever you're needed, we want you. And that's that's years of educating and being present. And so I go to all ICU meetings, trauma meetings, just because there needs to be a speech pathologist at those, or someone representing rehab. And it's usually a PT. And I just decided I really think it should be a speech therapist. Just do something different. Okay. Sorry.
No, don't be sorry, Joe. That was wonderful and so important. And I always think it's better doing an assessment with other disciplines, because for me, I'm also learning from them things that I may not have looked at initially, but at the end, we're evaluating a whole person, right? So it's always good to get all those perspectives. For anybody who has additional questions in the audience, I'm going to also leave my email in the chat, so you can feel free to reach out to me. This talk is recorded and will be available on demand on both the YouTube for Aspire Respiratory Products, as well as the healthcare professional side of the website, which is emst150.com. And I will put that out on the social media as soon as it's available, usually in a few days. So
Jenny, can I say, for those that are asking for more citations and, check out my LinkedIn and my newsletter articles. I go deep into these topics and provide dozens and dozens of citations, as well as on my website. I have transcripts to every podcast episode and the citations. So you can even put in the search bar, speech language pathology, and you'll find episodes with SLPs. Delirium, you can look into whatever topic. There are almost 200 episodes at this point, so it's a lot. But there you can find many citations to the vast evidence available.
Yeah. And Callie, your website again is
DaytonICUconsulting.com.
I put that also in the chat. I encourage everybody to check that out. It is a great resource. And Callie's LinkedIn is the reason we're all here today, because I really support all the work you're doing. And Joe, you too. So thank you again. Have a good evening.
Thanks for joining the revolution.
Yes.
Bye.
Good night, everybody.